Yes.
كانوا زمان ما بعرف انه اذا في شك انه انه ما نعمل اسبريشن ممكن نعمل ديسيمينيشن لنفس
صحيح. يعني هذا at the early experience with fine needle aspiration, they talk about implantation of malignant cells along the track. Okay. With further studies, with this long experience with fine needle aspiration, usually this is it is not happening. It is not changing the direction of the malignant cells towards different lymphatics. Actually, things going in different directions, but now in general, okay, we do fine needle aspiration for all kinds of tumors accessible clinically or radiologically. Except, yes, in all cancers. Suppose that a patient having kidney cancer, you can take a percutaneous biopsy. If you have a patient having a liver cancer, you can take a percutaneous biopsy. The problem of seedling is not, it is really questionable. Now, before 15 years, it is established to do fine needle aspiration everywhere, except in two parts. One part is the testicular tumor, and the other part is the parotid tumor. Why the testicular tumor? Because you know that the testis, its lymphatic drainage going to the para-aortic lymph nodes. Okay? Now, if you do any interference through the scrotum, you may change the direction of the tumor to go into the inguinal lymph nodes, which complicate the issue. So till now, it is valid. Don't try to do needle aspiration for testicular tumors. Now, the people are liberal in doing this in the parotid area. زمان خاصة pleomorphic adenoma. يعني it has a character to implant. But the people with experience that doing needle aspiration in this side is quite safe. So there is no problem regarding the seedling of the tumor along the track. Sometimes the people say, yeah, if you are the doctor, you see the patient, you find the mass, and you didn't do the mammography first. Would you do the fine needle aspiration first, or you send the patient to do the mammography, and then you do the needle aspiration? In the modern practice, usually there is a press unit. The surgeon, the medical oncologist, the radiologist, all in one place, so that you can, within 5 minutes or 10 minutes, do the mammography. Do the mammography first. Why? Because when you do the fine needle aspiration, you may induce bleeding, okay? And this bleeding making pain. And you don't compress the breast in a proper way, okay? So that do the mammography first. Or, if there is a bleeding and there is no pain, but the bleeding will diffuse around the tumor, so that it will increase the size, the apparent size by imaging. So if you have the chance to do the mammography first, well and good. But if you don't have the mammographic facilities, probably you can do the fine needle aspiration. With time, with experience, usually this works well without hazards. Okay? Now, as we said that we put a 21 gauge needle and we put it in the tumor and it goes in different directions and we aspirate. The cellular aspirate وما في fluid بيكون زي sort of juice cellular suspension, and it will be spread on slides and it will be fixed by 90% alcohol and send it to the lab. Now you can drain some saline from this tube into the syringe and remove this needle and push the contents. Yeah, you do internal wash for the syringe. Sometimes there are a lot of cells there. And the cytologist, he will do spinning to the fluid and he will spread it and this will add more tissue to him. This is the concept of fine needle aspiration. Now, which is more important is the true cut biopsy. As you see that we have a special syringe here, this spring containing should be loaded before putting. It should be done under local anesthesia. We made a very small hole by blade number 11. Okay? And we hit the site of the tumor in different directions and we will take biopsies cores like this. You see the cores? At least you have to have at least 10 milligram of tissue to have to have a freedom to study the tissue properly. 10 milligram is 10 15 milligram of tissue. طبعا في عندنا الجيج is different. في عندنا ranging من 12 14 16 and so on. But when you take this and you send it to the histopathology, he will give you the nature of the tumor exactly, and he will tell you whether it is infiltrative or in situ, and they can do hormonal studies on this specimen. زي ما حكينا, it is valid هاي procedure if we want to have a new adjuvant chemotherapy. Now the people should refrain from doing what is called excisional biopsy. يعني one of the bad practice we see إنه مريضة بتروح عند الدكتور بحس إنه عندها نعاس وعندها tethering of the skin or retraction of the nipple, على طول بروح بحولها على العمليات. شو بيساوي؟ بروح بيعمل اكسجين للناس. اوكي؟ هلا بيجي الهيستوباثولوجي. الهيستوباثولوجي بيحكي لك إنه المارجنز involved so that this surgery is not complete. هلا إذا هو بده يرجع يعمل كمان مرة, he will find it difficult. Where is the tumor and what tissues he should take around. So, بنروح بدنا نقول لهم وين الماموجرام,